All right, everyone. Happy November 30th. Thank you so much for joining us. As people start to trickle in, we'll just give a minute or so for people to join the webinar. And thank you for coming today. Really thrilled to have a special guest today who's really going to speak to us about a very important topic that's been a priority for our lab and is becoming more of an emerging priority, even though it's long overdue, but in our field of sport and exercise medicine, and as well as in primary care and so on. So we're thrilled to have Olivia join us today to speak on unmet needs in clinical care. And so just as people continue to trickle in, we will go over our normal housekeeping items for this second last masterclass session. It's been a fantastic year for us. This is masterclass session number 12, and it's a bit of a bonus, but really key for us to be able to have Olivia here today. So I'll just go ahead and start, and then we'll get right to the session. So my name is Dr. Jane Thornton. I'm a clinician, scientist, and researcher at the University of Western Ontario in London, Ontario. And to start off our masterclasses, we always have a land acknowledgement. So I'll start with that today, that we acknowledge that this is sacred land upon which we are privileged to live and work. We recognize the deep connection and longstanding relationship between Indigenous peoples and the land of Southwest Ontario and of London. We acknowledge the Anishinaabe, Haudenosaunee, Lenapehoik, and Chinontan nations whose traditional lands were gathered upon here today. And we're deeply grateful to have the opportunity to be in this place. So today, the couple of housekeeping items that for those that have been attending the master classes to date will be very familiar with, but essentially we've turned off the chat and we're going to be using the Q&A today. The session is being recorded. And the introduction that I just gave was going to be followed by a 40-minute presentation, and then we'll have about 15 minutes of Q&A. And this masterclass in particular was developed with input from our scientific planning committee. So special thanks to Dr. Eric Wong and Dr. Sadia Jan. And this is just a friendly reminder that this is a bonus session and it's not accredited for main pro credits. And I have the pleasure of introducing our speaker today. Olivia Ghosh-Swaby is a PhD candidate in neuroscience at Western University. She's a Vanier Scholar, nationally recognized for her leadership skills and scholarly achievement. She's a student athlete and a strong advocate for equity, diversity, and inclusion in academia and sport. She's been playing football since 2008 and led the creation of the Ontario Women's Intercollegiate Football Association in 2017. And it is such an honor to have you join us today, Olivia. I love your advocacy and the attention to detail that you've put into this. And we're very lucky, I think, as we mentioned before, that this is a really critical piece for us in clinical care. And really look forward to your insight. So I'll stop my video now and we'll come back on at the end. But thank you.
Thanks for the kind introduction, Jane. I'm really excited to have this conversation today and really open the floor and provide maybe some insight in how clinical care for athletes can really take on an intersectional approach. And so I'll spend the beginning of this presentation going over that intersectionality piece, and then highlighting and honing in why it's so important. And then at the end of this talk, I'm going to really just go right into experiences that I had and experiences that many teammates and those within football, flag football, and a newly emerging sport are starting to go through as they move through their own academic and athletic careers. So disclosures of financial support, you can see them here on the screen. And then in terms of mitigating bias, as I said, I'm presenting my own personal experiences and anecdotes. And then a lot of the information that I try to provide is backed by literature work. So I'm doing my best to present that in a fair and balanced way. Here are my disclosures. So I currently have mostly relationships within the not-for-profit space, and of course, as a student as a doctoral candidate in neuroscience. And then I sit on executive committees for Football Ontario and the Ontario Women's Intercollegiate Football Association. So I'm going to jump right into it because I think one recurring theme that came up as I moved through speaking with athletes and focus groups about their experiences with injuries, but also understanding my own experiences. I think intersectionality is the key term here that I want to hone in on, as I had mentioned earlier. And this is really the big piece of that equity approach. So when we talk about intersectionality, it was coined by Kimberly Crenshaw. It's a theory that argues and really highlights that groups are multidimensional and they hold multiple different social statuses. And so we can't consider them independently. They need to be considered tandemly. So when I say when I refer to these social statuses, I'm talking about anything from race, gender, sexuality, ethnicity, social class, age, citizen status, mobility, nationality, body size, education. It's super multifaceted. And understanding those simultaneously and how experiences are dictated by all those things as one and not independent is important as to what athletes are receiving in their care, and also how they navigate return to play, how they navigate their own treatment and recovery when it comes to, for example, sport injury or even their own experiences in exercise. So a lot of this work, and I always like to highlight this, in the past, when we start to look at some of these social statuses like race or gender, they're often considered as their individual variables. They're not considered in tandem. And then it's often taking on some sort of added approach. We add a covariate, or we add an additional piece like age, social class on the side. Again, not encompassed together, all often as separate. So when we start to consider these pieces as one, it really shapes what an individual athlete may need in their care. And that's something I learned along the way. And on top of that, and I'll talk about kind of all these intersectionality pieces if we were to kind of put it into steps. It's primary care is kind of the focal point and the starting space that many athletes go to when they think about their own clinical experiences and how they move forward in sport and participate in exercise. But it is a team approach. It comes with the coaching, it comes with the nutrition, it comes with the physical therapy. All of that is part of it. But what I want to highlight is at the primary care piece, we need to ensure that athletes have the resources and understand the importance of this intersectional piece so that they can have a sense of agency in their care and that they've been heard and listened to with that kind of equity lens from someone that they trust. And so some example of approaches that need to be considered, for example, size inclusive. So knowing that sometimes this exercise is medicine and what the exercise environment space looks like tends to favor a specific body size, that those who are outside of that norm, how are they considered and approached in this conversation? Agency, that's a big one, knowing that the centered approach is around the patient, it's around the participant in exercise, and that you need to understand their needs in how they participate. And that as those who are delivering care, you are also advocates. And that the more curiosity you bring and the more discussion about some of these intersectional pieces and what an athlete is experiencing as they go through their care and treatment plans, that you are advocating for their success in return to sport or staying within the sport. But even though I'm asking primary care, those involved in primary care to think about these things, as I spoke with colleagues and I move in this space within the sport world, especially with women, many athletes themselves don't recognize how their own identity will impact their care. And I think that's important because some of these things, especially externally, aren't advocated for or discussed in their care, will impact or maybe have completely changed their prognosis up until 2 or 3 years after injury. And I'll kind of highlight that as we move through today's talk. So in the work, and when I kind of fall back to the literature, that's what I naturally do as a researcher as well, is what are kind of all of these pieces when we think about intersectionality. And intersectionality is kind of more of those interpersonal factors that could be like the attitudes towards physical activity and exercise, your own genetics, your own age, your gender, your education, your income, because those are kind of the things that you have as part of your own identity. But then it goes into these kind of macro level pieces. And I want to highlight that here. It's also the social environment they're in. Are they always engaging? And athletes tend to be surrounded by other athletes, and those kind of become their networks? How does that impact their return to sport if following injury? How does that change their own identity, especially if they identify with being an athlete so much? How does that change their mental health, their stress? And then when you add on being a student, what does that look like in terms of their care as well? And then when we look at it at the next level, like their neighborhood, their income, what area that they're in to receive care, can they go to multiple surgeons, for example, to get recommendations? How intensive is that process? How taxing is that process? How close are you to recreational facilities in season, out of season? And then knowing, okay, maybe you're someone who's more involved in the community within sport. You're also advocates in sport. How does that change their own care? Lots to think about. And then when we go to another level, it's also the policies, especially when we understand how things are very systemic. How do we make those changes so that we can support as many people with all these different identities as possible? Again, it's challenging, but it's a collective response and something that you get more informed of as you move through and take on this intersectional approach. So when I think of some examples, again, falling back onto the literature, and I was really curious what the perception of physical activity and how that varies by certain identities. So if we look at, for example, someone who's within a racialized group or visible minority for men, they tend to engage in more physical activity and exercise when they're of higher income compared to their majority or white counterpart. Whereas women tend to engage in physical activity in different ways, mostly to kind of find that community support. But what's interesting that those who have an intersecting identity of being a part of the LGBTQ2S plus AI community, they tend to engage in sport than those from those who are within a group of women than, for example, those of the same community within a group of men. And so it just, again, it's multiple, like there's a lot going on here. It's multi-dimensional, and that physical activity and how and athletes engage, return, and play in sport are dictated by that. In my own experiences, and again, I will speak to my own identities as we move through this talk. Some things that I was able to have access to differed because of the community that I was in. And that actually changed with the locations that I moved in. So I started in Brampton, which wasn't the greatest neighborhood that I was in, low SES, so low socioeconomic status. And I was in a single parent household. I have a ton of different identities that impacted how I participated in sport. But then I had community support in that area of being swimming competitively. So I had access to a pool that was offered to me at a discounted rate because they understood kind of the background and understanding the importance of physical activity in youth. Then when I moved out into Mississauga, I didn't necessarily see that same opportunity. So I left the sport, and my sport changed to what kind of was the bigger sport in that area, and it was volleyball. And then when I went to university, it changed again. And a lot of my identities around that shaped the sports that I took on and where I kind of fit. My body size dictated that. I'm a lot smaller than I look on computer, and that changed the sports that I was able to participate in, even my own care. And I'll talk about that as in respect to my own injury. So again, all of these things really highlighting that intersectional piece. So what does that mean in terms of breaking it down as actionable items of taking on this intersectional approach in care, and what I was able to talk to with other athletes and understanding my own care? So here are some things that I wanted to capture. This idea of tailored treatment. So considering these identities will help shape that, knowing how rehabilitation plans or return to sport will look like. Identities are really essential to that. So again, when they go back to sport, are they living on their own? Are they a student? Are they of a certain body size? Do they have access to physio than everyone else? And then how does maybe gender play a role in that, or their own race play a role in that? Then understand being culturally competent is really important. So, and I'll provide an anecdote later that talks about how this cultural influence on how you perceive an injury or how you perceive the importance of participating in sport and kind of staying or leaving in it is really dictated by the value that is placed within those communities. And that's really important. And how communities value or understand kind of the historical factors that play a role in that will dictate participation in exercise and also care. The other piece is addressing barriers. Can you identify how groups of certain identities are disproportionately affected by the systems that we have in place? So is that an economic barrier? Is that related to finance? Is that related to accessibility and ability status? Is that cultural? Again, cultural competence comes back in that conversation. The other piece is representation, not just who they're interacting with. I think one big piece, especially when you think about, again, I keep coming back to cultural competence, but if you're seeing someone who may understand and be able to empathize with your experiences as an individual within your communities, within what you're going through on a daily basis, that the care and delivery of care can be even better. And knowing that it is diverse and that those that you are supporting are from diverse communities. And that can even come with education and training and promoting this idea of diversity inclusion within the field of medicine as a whole. And where are we founding our guidelines and how we're supporting and providing care? And that comes with the research and data we collect. Who is involved in that process? Who's examined? Are those heterogeneous? Like, is it the same group of people that we're always looking at? Are we excluding women, for example, in how we look at ACL reconstruction? Are we getting enough data to help support all of these different identities? Knowing that the communities that we work in don't all look the same. Everyone doesn't have the same background. And then kind of community engagement and policy are one and the same. Again, addressing things systemically requires some sort of policy level change, but you need to engage the community to know what that looks like, and you need to create a safe space to do so. And that's something that I've been learning as I move through sport delivery and understanding what those within flag football are going through. And so, like I mentioned, cultural competency keeps coming up. And so I wanted to highlight that in this next slide and provide kind of why it's so important and where intersectionality is really big, a big element of that. So valuing diversity. So as someone who went through different injuries, the curiosity of the person or the primary care provider who was asking questions about me personally, my lived experience, and continuously getting that feedback or asking for it, show that they valued diversity. They wanted to know those experiences and how that might be a factor in my care. And then what I would hope on the back end is that whoever is providing this care, this healthcare provider, is assessing their own cultural beliefs, values, and biases, and having that like internal access to cultural competency, and how that may play a role in how you manage their care. So when you come back and you talk with me, for example, about my care, do we align in our own personal beliefs? And if we don't, how do we engage in the treatment that I want to take on in a meaningful way, in a mutually respectful way, and finding something that would work within both of our beliefs? And that might even come with education. And that's something I'll also talk about with the anecdotes that I provide. And then acquiring and using kind of cultural knowledge. This is an important skill that I've learned in how I go about advocating for my own care. And then knowing that providers, especially if we see the changes in curriculum, are understanding cultural beliefs in different groups and the implications for that in clinical care. And then finally, adapting to these differences in communities, whether that be at the healthcare provider level, but working as a partner with your patient in terms of how to go about their treatment plan. Something that I didn't have as I moved through my own injuries in sport until I became more versed in this space. And that's, again, the education piece. So all in all, by applying an intersectional lens in exercise medicine will really help primary care providers move towards a more equitable and inclusive praxis in how they deliver care, how you apply certain exercise interventions or interventions to return to play, and of course, promoting better health as a whole within communities and within the athlete experience. So what does that look like in terms of flag football? Because that's my background and that's the space that I work with. And I like to show the models that we take on in kind of the space that I advocate in. and then how that can dictate care. So the Ontario Women's Intercollegiate Football Association, again, was founded in 2017, kind of became whole more so in 2020, and we're pretty young and pretty new in how we deliver things. But one thing we wanted to do was do that in an informed way and use toolkits and resources available to us. So the Canadian Women in Sport Foundation has started up the Same Game Challenge, and it provides this gender vision or equity approach to how we deliver sport. And it's very similar to how we deliver care. It's very similar to knowledge translation of what we see in research, is that you need to know the population you work with. You need to come up with a plan. You need to communicate with those members that are involved in that care, implement what you think the guidelines are, and then reflect and revise. And so one place that we started in within this association is understanding what athletes may be navigating. And that can be their own athletic identity, who's making decisions and how their sport is delivered, and understanding that'll have a greater impact on their academic careers and how they move through their future participation in sport after college or university. So when we start taking on this equity vision and approach, there's a lot of things that we had to consider and think of. So the access point to this sport, it's a new one. It's just got added on as an Olympic sport for the 2028 LA Olympics, something that I'm extremely excited about. It's a new sport, so kind of injuries are at play here, and what are the needs of this group? And so we wanted to first identify what our population looks like. So on the right of the screen here, we break this down more. We have about 500 athletes that participate in this association within Ontario, 70 coaches. And of that group, and we had 200 respondents in our equity survey, 209 that are athletes, about 50% are racialized, 33% come from the LGBTQ2AI+ community, and many say that their career and entry into the sport was limited by what grassroots programmings were available to them. Stuff that we understand and we know, and it has kind of shaped our vision on how we deliver care. It also has dictated how I've gone through my own injuries and experiences in sport. And so when we think about that entry level to sport and why it's so important, is a few things. About 50% of our membership started flag football in university or college, whether that be competitively or within an intramural sport. And the age of participation is over the age of 18 mostly, with a few starting even earlier in high school. But it is a newer sport, which I like to highlight. And so there's a few things that we think about when we think about exercise and movement. And as a researcher, as someone that I've been curious about in this space as well, and even in how I receive my care. Does entering a sport later mean more injury? Does coming from a different sport background, which majority of our athletes are, they played soccer, basketball, volleyball, does that make them better equipped to actually handle the change in the sport? And what the literature shows, for example, and has speculated, is that multi-sport athletes, for example, are less inclined to be injured later in life. And so that's cool. And so when I think about what we see in our own population, we did ask what injuries do they get within an OWIFA season. These are the type of injuries that we see within our group. About 44%, which was actually a surprising number as someone who thinks that we see injury fairly frequently in sport, was that 43% had no injury. And then the type of injuries tend to be more of the surface cuts or bruises. And then there's the sprains, the rolled ankles, the torn ACLs, and then fewer head injuries because this is a non-contact version of the game. So this is a non-contact version of flag football. And to think about this in respect to other sports, and when I see torn ligaments or the idea of a torn ACL, we know that women, for example, are at 8 times more risk of having an ACL tear and are even less likely to return to sport after injury. And then in other sports, like for example, soccer, and this is in a study that looked at the NCAA, they found that about 115 athletes with regard to knee injuries sustained that via contact and about 150 saw that via non-contact injuries. So it's interesting to see in that in this sport, and this is again, only descriptive data, we didn't analyze or look at it compared to anything else, that the injury that we see isn't as frequent as you'd think. So when we come back to these ideas of primary care for athletes, going back to the kind of these 7 intersectional approaches that I highlighted, what does that look like when we start talking about anecdotes? And I want everyone to kind of think critically about this as I share different experiences that athletes have had within this sport. And it often comes not within flag football, but outside of that in a previous injury. And then I'll talk about my own care as well. So here's a testimony that I received from one athlete. I put their identities on there, the sport of which it was in. These are all current flag football athletes. So the sport that they're talking about is where the injury had occurred, at the age of their injury and then their current age. So in this example, this is someone who had an injury young, and it has, in my discussions with them, has impacted their career and how they engage in physical activity up until now. And they're 20 years old. So 7 years later, they're still feeling this, the impact of their injury. They were misdiagnosed, and it was quite an extensive set of diagnoses. And what she mentioned, and again, the educational piece wasn't quite there at such a young age, but if that was also shared and discussed more, they would have probably had a bit more agency in their care, or even their parents at that time. Was first the physicians that they had met with were worried about the age and that there's growth plates involved, and that might impact the type of injury that the individual had. It ended up being an ankle fracture by their 7th consult and imaging. And then this athlete didn't really know if this was something that could have been preventative, and it was a contact injury. Someone landed on their ankle, and so it resulted in the fracture. They did mention the idea of a brace. I'm not totally familiar, but I've heard mixed opinions about using braces, using kinesiology tape to prevent injury. And then they've had long-term outcomes after this. So they feel like they no longer have strength or mobility in their ankle, and they have chronic pain. Also, they lost communication with that surgeon at the end. So they actually never had a surgery to help correct their injury. So it's now something that was really done with whatever came out of the walking boot for them: physiotherapy, massage therapy, all of these methods that they used to help improve and remain in sport. And then this individual also identified with their injury by the end, because this person was a tall woman. She was constantly reminded in her care that she is bigger for her age. And so that likely contributed to their injury. And so they remained identified with that energy, with their injury. And so the intersectional piece that I wanted to hone in here is a few things. And if I were to show you that diagram again, there's so many elements part of that. Things that she noted was the age at which their injury happened, the lack of education on what that injury means for not just their care, but the future, how they participate in sport and remain active. Luckily, they're still active and playing flag football as a result, but are still having these long-term mobility and strength issues. Their body size has now become a constant thing that they identify with and feel as if it's outside of what is seen as in the exercise and space. And their mental health significantly deteriorated at the time. With management of pain, it's gotten better, but it's something that has impacted even into their academic careers today. So that's the first perspective that I wanted to provide, and how considerations around that. And as you read through these, what could their care have looked like, and how could it have been approached differently? Here's another testimony that we had. This was someone who's East Asian, understood that they grew up in an urban location. So they did mention they were able to go between different hospitals to see where they wanted to choose and get their best care. And that their university education now has prepared them for their second injury. As you can see, they tore their ACL at 20 years old, but at 13 years old did not have that type of education to prepare them for recovery and preventing even this next injury after. This is, again, a flag football athlete, but their sport of where they were also injured was soccer, and this is common. Full ACL tear and partial meniscus tear. Preventative, unknown. A lot of the things that many highlighted was the recovery period, as well as the strength and building strength around muscles for the type of sport that they're participating in and at what level that they're participating in. And as a long-term result, both knees still have swelling, especially with overuse, and there's patellar tendon pain. They did acknowledge that although they didn't identify with their primary care providers, and in this case, their surgeons, that piece and that element that I mentioned earlier about having a mutual partnership with your patient really helped ensure they felt that they had a positive experience, which they highlighted, and that they, especially in their second injury, knew the importance of physio before and after. And then that education piece, when we start thinking about intersectionality, this patient had more agency in their care because they are a kinesiology student, which not everyone does. So they were able to ask more questions than the average because they knew kind of the mechanism of injury and the type of recovery that is often discussed within their classes. But not everyone has that. And she didn't have that when she was 13, which she highlighted. And then there were other things that played a role in this. Her mental health was severely impacted because she didn't know if she would remain and return to sport. And flag football kind of became that space for her to come back into sport again, even with having both knees with reconstruction surgery. She found that there was more academic pressure also going through care. And know that she had to balance more as both being a student and an athlete, but had her parental support in deciding what that care looked like during the summer and during the off periods from school. Here's another testimony. This is another student. Again, flag football was her injury this time. It was a non-contact ACL tear, and she's 9 months post-op. She definitely understood the value of strength training and helping prevent this injury, something that she wasn't engaging in now at the time, but she is engaging in now, especially since her goal is to return to sport. Although she already has long-term outcomes, so stiffness in the knee, some pain, psychologically, because of how much she identified with being an athlete, she lost that significantly and has now had to transition into contributing to sport in different ways. And now they coach. She had one surgeon, one consult. She was scheduled into several MRIs, but they weren't able to be done until 4 months after the injury. And then the surgery was then 4 months later. So she did wish these wait times could be reduced, but there's a whole other set of barriers to that. But that's something to consider in their care. And she understood she had access to care. So she got, she knew she could get care within the London region, but then went to Toronto to then find something that she felt would be best for her recovery. Here's another testimony. Again, you can notice that there's some recurring themes here. A lot of the long-term outcomes is pain. And in education is a big piece, especially if those had injury at a younger age before they came into university education. Many are women, so the type of injury seems to be a recurring theme, and a lot have noted body size being a role in this, and that their mental health also deteriorated over time. Here's one testimony that I had that came from someone who identified as a man who grew up in an urban location, but is from the South Asian community. And this is where I wanted to talk about the cultural competency piece that they were able to highlight. Their injury happened in basketball. They also had identified with the body size element because post-injury or post having issues with the knees, gained significant weight and wasn't able to remain in sport as a whole. And that weight also further contributed to knee pain. But within a cultural context, they were told to kind of toughen up with the perception of what a man is in that space. Didn't quite understand the value of how much that individual identified with being an athlete, because in the end, it was their education that would get them further in life. Although we know the benefits of sport on health, mental health especially, and even soft skills that you build as part of that. Continuously wears knee braces to continue in their current sport, or really just exercise at this point, as they did not return to sport. And then they also had this mental health piece that they had to be more aware of. And when we think about South Asian cultures, and when I went to look at the literature, many of it is kind of this collectivism idea of what the value of exercise is. And if it's not told to them by a primary care provider, then they don't see why they need to engage in physical activity in the same way. So here's my own experience. And that's because I do have a little bit more understanding of this intersectional piece and how I received care. And then as I reflect back, I realized, wow, my identities really did play a role in this. So I'm biracial. I'm both Black and South Asian. I mentioned this earlier. I'm a single parent. I'm low socioeconomic status. I'm currently a student, and I'm cisgender, heterosexual. I'm small in body size, so I'm 5'1" on a good day that I joke about, 5 foot most of the time. And the sports that I played in maybe weren't conducive for my height, which was volleyball, but I loved it, and it was something that I was able to play at a high level. And when I was 15 years old is when I first tore my ACL. But I didn't even know what an ACL tear was or what the mechanism or thought of that kind of injury looked like. I wasn't training. I was a track and field athlete too, so I had to actually stop hurdling because that was my event because my knee kept coming out. My mom had no clue how to address this injury, even when it happened, that I didn't go to the hospital. I didn't see a physician right away. And that's because of this lack of education around injury at that age. And oddly enough, it was, and especially in many other South Asian communities too, it's your fault that this injury happened. And it was a non-contact injury. So I don't know how I could have prevented it besides actually taking care of kind of the strength piece, but it was my fault. So I had to get over it. And so I returned to sport pretty quickly, about 3 or 4 weeks later when I thought my knee healed up. There's definitely no ACL there. And that was confirmed when I re-injured that knee later with the meniscus tear. But I was able to return to sport. I had these instances of knee instability, knee coming in and out all the time, something that I just kind of toughed through. It was painful, but not something that stopped me. And that might be my own perseverance. And so I had no primary care provider that I worked with at that time at 15 years old. And I was able to return to sport, and I actually picked up strength training in my last 2 years of high school. And that has made me a better athlete as a whole. And I didn't really have that knee instability to the same extent. So it was essentially physiotherapy that I never pursued formally. But then when I went into university, I had the intention of playing on the volleyball team here at Western. I had torn it playing volleyball, or torn my meniscus playing volleyball again. And that resulted in a flap. My knee was locking. I actually couldn't really participate in sport again. It wasn't healing. It was constant swelling. And that's when I knew I had to go to a surgeon for that to be repaired. And then I had the repair done. My only issue in that care was that curiosity element wasn't there. So what were the experiences I was going through? I definitely identified with being an athlete, knowing that if I don't have the surgery, I may not be able to play sport at a high level again was a lot. I went into a depressive state. Post-surgery especially was the case. In the care that I had, this differentiation, and especially when I moved into the football space, flag football isn't seen as a varsity sport. So the level of care felt different when I was going through this. And so the projected time of which I would have my surgery, even though I play in a sport that I wanted to return to right away, was scheduled for a year later. But I managed to get in within a month later to get that surgery done after the meniscus tear, which is something that I think actually made that process a little bit easier for me because it was like ripping the Band-Aid, let's get it done. Scheduled it 3 weeks later, went in and did it. And at that time, I was provided really good information on why we need to strength train before going into that surgery. Again, I didn't get in as many sessions in physiotherapy as I could because of my low SES and I wasn't under my mother's insurance. I had a very small amount of money to spend on physiotherapy, and that continued after that. I couldn't always engage in it in the way that would help prevent future injury or future pain. Additionally, I had no clue what the surgery I was about to get included because it wasn't consulted in detail with me. Maybe it's because I didn't have the education to go into that detail. But as I moved through my own career in the medical sciences, I knew after, it took about 3 months later at post-surgery to know exactly what was done, why I was on crutches longer than the average, because there was a cartilage repair where a microfracture was done. Didn't know that until 3 months later. And that came from a resident who wanted to take me through what was done. I didn't quite understand what a bone contusion was because of the jamming of the knee when I tore the meniscus again, and what that bruising resulted in, which included some of this cartilage injury. And this ACL tear, I was short. So what I was told is there wasn't enough hamstring graft. And so I had partial hamstring and partial cadaver used to create my ACL. And if I knew kind of the injury rates, I would have taken more time or recurrence of re-tear. But I knew that that was higher when, especially using a cadaver, or the potential risk, even surgery, post-surgery, I would have been even more attentive to my care. But one really good thing is, and it's the strongest I've ever been in my life, I took up exercise because I knew I couldn't play sport as part of my own mental health journey, and knowing that I wanted to get my ability to its best. And that was because I also couldn't afford physiotherapy, but I had a gym membership as part of being a Western student to continue doing that care for myself. And so I did that for me. And now I literally live for exercise and I encourage it. It's become a part of my own research work 3 years after post-injury and kind of dictated where I am now. I do experience chronic pain. I also didn't understand how the scar may even impact my own pain, because I had pain in my scar tissue even 3-4 years later. I still will have swelling. And then because of some compensation, I have injury in the other knee, which I'm now taken care of pretty well because I know I've gone through this process before. I've had other injuries in my rotator cuff, but the care that I received in this case was much different. A lot of imaging was done. A lot of questions were asked about how to prevent this and how to find it. And I haven't had an issue since. So these are things that I've learned along the way, and in which the ways in which I ask questions were very different than when I did previously, because I've had experience in this process. But as you can see through my own anecdote and my own experiences, body size, the cultural experiences I had, the access to care that I was able to afford, my mental health, and how that was never even talked about. I was lucky to have friends nearby. My mom couldn't stay because she couldn't leave work. So I was crutching 3 days post-surgery to get myself to physio down the street because the buses couldn't get me there. I crutched all the way up Oxford to get to my physiotherapy. I also understood the accessibility needs and how terrible accessibility is on campus as I went through that. And I was on crutches for an extended period of time. Or even knowing that there is a bus I could have called to help get me to my classes. These are the things that weren't provided in my care. And I think it could have made the process a lot more enjoyable however it could have been, sped up, and even stronger results in recovery after. But knock on wood, I have not had any re-injuries of my knees, besides what you get from wear and tear playing a sport at a high level. So just to kind of wrap up today's conversation, I want to go back to the idea of this intersectionality piece, the individual athlete, and understanding and being curious about who they are and what they're experiencing, but how does that relate to their healthcare provider relationship? And if you're talking about a student athlete, what that looks like on a campus level, within the campus community and within their own personal communities, and what the societal pressures and social determinants of health actually dictate that. And these are like 4 key things that I think should be addressed. So age has been something that had come up in education level at times, whether you're an adolescent or a young adult. What does that look like at an individual level, and addressing their needs? Using these strength-based approaches and understanding that cultural competency is a huge element to that. Integrating this medical care. So I mentioned this kind of quickly, but if I were to be connected with accessibility services on campus, as I was on crutches and unable to walk as easily, if I were able to be provided with the wellness center on campus to help me get through kind of the identity piece with being an athlete and not being able to participate in sport, which brought me community and so many of my friends. If I knew nutrition played a role in that, all of these things would have really changed the agency in which I pursued my own care. And then promoting this, and that it needs to be more front facing within our clinical spaces, that when I walk in, have you thought about XYZ? Is there a sheet you can give me about understanding this? Oddly enough, at the time of my injury, the person that showed the most care and kind of understood my experiences, they're actually a mentor of mine now, was someone doing research who wanted to recruit participants who had recent ACL tears and injuries. And that's because they understood the impact and that maybe their research can help better inform clinical care. And then again, how does identity play a role in that? And if you're thinking about the student athletes you might be working with, I know flag football is unconventional because it's not in an Ontario University athletic space that you normally see, but this is data from the OUA anti-racism report. A huge chunk of those you're working with, I know it's still white dominant, are those from other ethnicities and racial backgrounds. And so understanding what their care looks like and how that's dictated by their identity is super, super important. And so here are those key takeaways. Recognize it's beyond the physical needs. I did talk about my injury, but that wasn't really the crux of what I went through. It was all the other things around it and how I had access to certain things versus others. Education, recurring theme. Why did the injury happen? What could have been done to prevent it and prevent it happening again? And how can that dictate your care? Where are you within your own education? And how best do I communicate that with you? This intersectional approach, so understanding cultural competency in your approaches to care, and then applying a holistic approach to care. And that's what these steps were on this slide, this holistic idea. And to recommend and incorporate not just within the primary care providers, but also allied professionals that are a part of this process in the physio space, in the nutrition space, in the mental health space, to make this recovery and return to sport even easier. So I will stop there, and I thank you all for listening to me, and I'm happy to answer any questions.
Fantastic. Thank you so much, Olivia. That was so brilliant. I mean, I think we don't use anecdotes enough because you can imagine just how powerful it is to see what lived experiences people go through and things that we, as clinicians, I don't think we fully take stock of. And anyway, those were really powerful anecdotes. I appreciate that. And I also think, as we're thinking about this in leadership as well, the sense of cultural competencies, but how do we approach cultural competency in things like sport and exercise medicine and primary care, right? Like, I think it's just such a big part of it because, as you say, I think to a clinician, say a busy clinician who maybe didn't get that medical training on those specific subjects, how do we kind of incorporate that into our practices and kind of where do we start? Because you beautiful graph on intersectionality, but and then, I can also imagine the overwhelmed physician thinking, I'm just trying to get through my day. Where do I start? So I have a few questions. I ask the audience as well. Please feel free to drop in the Q&A if you have other questions as well. But maybe if we just start there, I'd love to hear advice that you might have for, first of all, maybe we start with physicians. What do you see as a first step? Because you've mentioned asking the questions, but I wonder, what do you think, like the advice that you could give us as clinicians in the sense of where do we start? Not that it has to be on you to teach us, but
no, for sure.
Where do you think, like, where do you see the value that, would come out of those kinds of conversations?
I know I've been in the clinic space, so I know how many patients are seen in a day. So I completely understand that it can't do it all. But understanding that you can maybe lean to some of the support structures because we are in a waiting room could be for a period of time. So is there support services that could be added in there to just kind of consult or chat with the person who's coming in? Sometimes a nurse will take down information and ask you more. Can that be the time to be curious and then add those notes in for the physician as they come in? And then, like I said, that curiosity piece. So asking questions, it could even be as simple as like, how are you doing? And then go into what the injury is or what's preventing them from being kind of their fullest athlete. And then I know like you want to get to the treatment plan, but what if, especially someone who's educated like myself, I know sometimes what those things could look like, but what could get me back to sport, I guess, is what sometimes is needed to be asked. And how can I do that safely so that it is sustainable?
And I think that's fantastic. Like, I think to your point, as you're saying, it's not even just the injury, right? And I think as clinicians in any field, we tend to try to fix things and try to get to the answer right away, that treatment plan, as you said. But also thinking about that mental health aspects, which I don't think we talk about enough in terms of the injury. How are you coping when it's such a big part of our identity, essentially, with sport and physical activity, right? It helps mental health, as you say, most of the time, it helps our mental health. But then just that ability to talk about those things in clinic as well, to kind of check in, seems to be, I think we probably underestimate the importance of asking those other questions. I think back to a really nice example about saying, well, it's, in South Asian cultures, it could be that it's essentially your fault for being injured or something along those lines, and how easy that would be as a clinician to kind of bust that myth a little bit, right? Like how much it might add value. And I mean, I remember, personal experience as well, thinking about the educational aspects. Sometimes it's just taking that moment to normalize the situation, to say, this is what we can expect, to help kind of coach and help people see, the benefit of what they could do through rehab, kind of give other options. Like, I think it's even just taking that extra few minutes can really make a big difference. And so it just was really impactful on me when you were kind of sharing your own story and things like that, in the sense that there's probably easy ways. Yeah, go ahead.
Yeah, I was wondering too, because I always think about this, because if this is like more of a systemic thing, and let's say we approach the mental health piece, and I don't know what the literature looks like, and I don't know if it's been dived into to this level, but let's say an athlete loses their sense of agency, and they've lost their identity, and their mental health deteriorates. They don't go to physio, and they return back to sport because they're ready to play in their head. What happens when they re-injure, and how does that change how your clinic is practiced? Like your practice looks like, right? Because you're going to have someone coming back again, and using more resources and more, like, I'm trying to think if we can tackle it at the beginning, it'll reduce the burden on healthcare providers in the future.
Do you mean in the sense of giving them an appropriate understanding of their re-injury possibilities, or do you mean
re-injury, even just understanding that their body as a whole and returning to exercise can help prevent injury even in other parts of their body, and limiting kind of the care that is needed for them as a whole?
Yeah, I mean, I think that's a really important question, and you've touched on it, as well as the sense of there's part of being functionally able to return to sport, and then there's that mental readiness as well. And I think it also depends, and maybe it's another check-in with the athlete. How much do you want to know? I mean, is it beneficial for you that you have to know if there's an increased risk of ACL injury in the other knee, for example, or maybe not, or maybe we talk about ways to prevent that a little bit more on a follow-up visit or things like that. I think how in that sense of how much that shared decision making, or how much knowledge would you like, and even our best research, right, it's always going to be imperfect. There's always the individual case, but those are great questions. I also see a question in the chat, and I know we have about 5 minutes remaining. I do want to come back to this advice, maybe from a patient perspective, and how you can advocate for yourself. I just want to go to David Howe's question. And so it might need a bit of clarification, but maybe not for you, Olivia, but for me, maybe. It's he's asking, what theoretical approach are you using to unpack the data? So I'm not sure which data is that. Is that the OUA data, or is that something else?
I'm going to assume, so David, correct me if I'm wrong, you're referring to the types of injuries that we were able to collect in our equity survey as part of our Flag Football Association. And then the theoretical approaches, because I did suggest a few that have come up in the literature. So whether that be size-based, whether that be these agency-based social justice, or even kind of that holistic approach to how we go about that care. So this is something that I am reflecting on more. And even as I did this presentation, I'm trying to figure out what the best approach may be. Again, I think it has to be this more holistic approach, because there are so many identities. So it can't just be the size-based approach. The agency one is hard because it's a lot of people to educate. And so I think education is probably the biggest place to start, but it'll be, okay, who is the group that we are serving the most, and how can we ensure that they are best educated on that idea? And it's, yes, the qualitative data as well, and what I was able to get anecdotally. These are things that I'm consulting with the groups. A perfect world is I apply for a grant and get this kind of work funded. It's a little bit as a side project for myself. So I'm unfortunately not paid to do the work that I do for that association. But yeah, I'm thinking about the best approaches. It definitely has to be intersectional. It may have to include, okay, the injury prevention side and that kind of agency in how athletes are supported in their care, or know where to start. So something that I'm working on. So I don't have a perfect answer now, but I now have all of this knowledge about intersectionality to best inform that.
Oh, thank you. And thanks, David, for the question. I'm happy to follow up if there's just to pretend. Oh, yes, you did say the qualitative data. Excellent. Thank you for that. So happy to follow up. Maybe we can, in terms of connecting each other so that you have a more fulsome answer if we haven't answered specifically, but I think that's fantastic. And with the remaining kind of couple of minutes left, just that question to come back to, Olivia, because I think, so there's that physician-facing education that I think we have to, I really do think the onus is on us as clinicians to be able to educate ourselves on these cultural competencies and asking about mental health and those kinds of things. So I really thank you for presenting that. And that's really fantastic. We really do need to value diversity. And, you know, as you said, even at least 30% or 30% or so of OUA athletes, right? Like in the sense of this isn't just a very, very marginalized population, but we have to be thinking more broadly constantly. And I just, maybe just to finish off, so without taking any of that onus off clinicians, what might you advise to athletes just to be kind of self-advocates or, you know, advocating for access or better care? Do you have any thoughts or tips for them to bring to their treating healthcare providers in general, in the sense of, how do they advocate for themselves when that might be actually quite difficult, or do they, if that's a barrier even to seek care in the first place?
Yeah, so seeking care is one thing. I mean, in a varsity space, you may have access to that a little bit easier than what I personally experienced in many in-flight football, so that I understand there are differences there. And I think when your first injury happens is when you start to develop those advocacy pieces. And that's why I think I'm more informed now, like knowing that an acute care clinic that you can call the day before exists, so that you can see someone right away to understand, okay, what is the injury that I've just had? And does this require more care, is something that you have to kind of be privy to know, like you wouldn't know otherwise. So as an athlete, and this may even not just for yourself, but encouraging it's a conversation with all of your teammates and your coaches. What are our resources available to us as is, just for our own care, whether that be injury related or mental health related. And then if we are going to go to a primary care, going to a provider for an injury, what are the kind of questions you should have and always ask? So I don't know if that exists. Like, you would know better than me, Jane, if there are 5 different takeaway questions that an athlete should always ask when they go into the clinic for an injury. What would that be? Mm-hmm. Some of the things that I've done and I've always asked is, okay, so could this have been prevented? What will the recovery process look like and how long? What is the injury? Because I'm not an expert in this space. Mm-hmm. And like, if I'm going to go through this rehab process, what would be like perfect amount of care to get me to where I need to be as fast as I can and as safely as I can? And what's the minimum? Because I may not be able to afford the maximum.
Yeah.
So understanding that. And then who do I communicate with, whether it be my family or my professor or whoever I'm working with on a daily basis, as to my needs now going forward. Like, will I need a bus to get around? Will I have pain throughout the day that might take me away from what I need to engage in? Will I potentially have an injury again in the future? Like, all those things that'll impact kind of the day-to-day as well.
Fantastic. I think that's a great list. I think we'll take notes on that, and that could be a good starter. Those are all things that I think we can help with. And no, I truly appreciate that. That's wonderful. So just because we are running out of time quickly, I just want to take this time to really thank you again, Olivia. It's outstanding to have you here on on our masterclass. And as you know, as I hope you know, that you've been really inspirational to me, and it is really a big honor to have you here and join us and help us understand a little bit more on intersectionality and thinking about valuing diversity, cultural competency, and things like that in our daily practice. So hopefully that does contribute to better patient care in the future from all of us. I want to thank all the participants for joining today. You will be sent an email containing a link to the participant evaluation. So please send that out. That's really helpful to our speakers as well as to us. And please email us with any questions or concerns. Our research coordinator's email is sent in the registration email, and she also dropped it in the chat, I believe, as well as the evaluation form. And please register for our next session. It's our final session. It happens tomorrow. So if you haven't already, please feel free to do that. It's through the Fowler Kennedy website. You can just Google Fowler Kennedy Masterclass, or we might have that in the chat as well. And again, thanks. It's 1 o'clock in London, Ontario time. So our time's up for now. Thanks again, everyone, for your questions and comments. And we look forward to seeing you again tomorrow. And once again, thank you, Olivia. It's been fantastic to have you on today.